Okay, good morning everybody, and welcome to this session presented by IAP, the Inter-Academy Partnership, on its Young Physician Leaders Program about effective leaders for effective health systems. My name is Peter McGrath. I'm the coordinator of IAP, and many thanks also to the presenters over the last few days of this program, Joe Buford from the International Society of Urban Health and Nora Grasselli from ESMT here in Berlin, that unfortunately can't be with us this morning. I think they're following online. So what exactly is IAP and what is our Young Physician Leaders Program? So IAP is a global network of academies of science, medicine and engineering. We have 150 members throughout the world, arranged in 4 regional networks for Africa, the Americas, for Europe and for Asia and Oceania. And this gives us access to, we estimate, 30,000 leading scientists, engineers and health professionals in about 100 countries. And this is because the academies, our member academies, are honorific societies that elect into their membership the best, the leading scientists and medical professionals in their countries. We work through distributed secretariat, 2 offices, one hosted at the US National Academy of Sciences in Washington, DC, and the other, where I am based, in Trieste in Italy, hosted by the World Academy of Sciences and administered by UNESCO. Through IAP and our member academies, we try to insert the vital role of science into evidence-based solutions for the world's most challenging problems. We try and get our academies working together to develop these solutions based on the best possible science, the best possible evidence. Amongst the long-running programs that we have is this Young Physician Leaders Program. We started back in 2011. But how do you get to be a young physician leader? It's a competitive process. We request nominations from our 150 member academies and also from the members of the World Health Summit Academic Alliance, of which IAP is a member. There is a rigorous selection process, and those who are selected are invited here to Berlin, and I'm pleased also to welcome 2024 cohort of 21 young physicians who are here with us today, and it's actually they that will be doing the presenting to you rather than me. So, as I mentioned, we work through ESMT in Berlin, and we have now an alumni network of more than 280 YPL. Of these, 66% are from low and middle income countries, and we have pretty good gender balance, 47% women, 53% men. So how do we get from our leadership training that these guys have been undertaken since Friday? They've had 2.5 days of training before they were set free in the World Health Summit itself. Only on Saturday at about 5 o'clock were they informed what was going to happen here today, what they had to prepare, and then they had half a day on Sunday to brainstorm what they wanted to present. So from that Sunday to this morning is Tuesday morning, they have been busy discussing, preparing, leading, working in teams and so on, and what you're about to see is what they have come up with. Here they all are hard at work in the different sessions from the workshop at ESTM, and I'm going to leave you there and hand over to this 2024 cohort of YPL so you can hear their stories and their discussions. Thank you.
Thank you, Peter, for presenting us and for the opportunity to be here in Berlin, participate in the Leaders Program. I would like to invite my colleagues to join me for this first panel that will start exploring the challenges that young leaders in healthcare face on a day-to-day basis. This first panel is going to explore the geopolitical realities that might be might be different from one place to the other, but might be very similar. And a group of us who from 7 different nationalities, is 8 actually, is going to explore and present how these challenges affect their daily work. I'm French and Lebanese. I started my medical career in Lebanon before 2015. And at that time, the main challenges I faced were the fact that I was a woman. There were no women neurosurgeons. So it was a very big battle for me to even get to my position. But there was also the fact that I'm a young person in a country that is used to the rigid system of elderly healthcare managers taking all the decisions. I moved to France, and there I was faced with another set of challenges. There was not really a problem with the fact that I was a woman, but my race posed a problem for some time before everybody got used to the idea that you can be of different identities. But the most rigid system that I faced in France was this very one and unique formula to get to leadership positions in the French healthcare system. With time, what happened in Lebanon, there was the economic collapse, there was the port explosion, and currently there's the war. The realities of what my colleagues are facing there it became different, and the challenges they face are mainly the paralysis of a healthcare system that occurs anytime there is a war or conflict in an area. What I would like to explore today with my colleagues is how these differences in geography and geopolitical realities affect how they work. So I'm going to ask Dr. Tiange to tell us a little bit more about the challenges she faces in China.
Thank you, Samia. So in China, I think our generation's challenge is competition. So recently, the significant increase in medical graduates, the numbers each year increase the supply of talent in the medical field. And in the meanwhile, the rapid advancement in technology also requires medical professionals to keep up with the rapid change of technology, and they have to update their skills and knowledge constantly. And this rapid change also increases the learning and work pressures on young physician professionals. So I think our generation's challenges in such a highly competitive environment. How can young physician leaders plan their career development? Yeah. Thank you.
Song, I'm going to ask you to tell us a little bit more about the challenges you face in South Korea.
Mm-hmm. Yes, the region in Far East are suffering from the low birth rate, and this makes our South Korea in the challenge of our social systems, especially including some systems that payers are young person and recipients are older persons. And in this case, for example, healthcare, doctors are working in departments like pediatrics, obstetrics, and general surgery or internal medicine are suffering from lower wage and longer working time because more patients and less payers. So recently, our doctors, especially young doctors, are avoiding this department, and it's become problematic in Korea.
Oh, it's very interesting that you touched down on the desertification of some departments that we in West Europe and France are currently suffering with the desertification of complete areas. Martin, how it is for you in Hungary, please?
We face, I think, different challenges from the Central European bloc. I think due to our cultural and historical heritage as a post-socialistic country, our main problem is the over-hierarchical system that we have, which is very much based on only clinical qualities. So basically, you can only advance in your field in medicine if you are good in medicine, but no other qualities are considered as leadership skills or other qualities. And I think it's difficult for the young generation to stand out in this aspect, because basically your future is dependent on your age and you have to wait it out. And that is not very supportive. And I think a lot of people are having burnout because of this, because they don't see necessarily their future role in this system, as it is not necessarily based on their achievements, but sometimes also based on who you know, who you're a relative of. And I think this kind of hierarchical system is counterproductive in choosing out the best leaders of the new world.
Thank you, Martin, for touching down on the rigidity of some systems and how they do not allow for any expression of different ways of practicing medicine. Marina, can you tell us more about the challenges you face in Argentina?
Yes. Well, I work in the public system, specifically in palliative care and medical cannabis and LGBTI plus health, especially in intersex health. And in Argentina, the public healthcare system is very robust and historic, with a third of the population relying on it. However, this last year, under the current government, which is right-wing and libertarian, there are three major factors that impact healthcare leadership. The first one is the severe economic and social crisis, which has deepened a lot now, and resources are very scarce. Medications, personnel, and complementary exams are in short supply. So leading healthcare systems is full with obstacles, because managing essential resources and medications becomes an urgent priority now. So this is frustrating long-term goal settings and also project planning. And other also innovative areas like this I work in face legal challenges now. Although laws remain in place, implementation and regulation right now are facing many obstacles due to their progressive nature. And for the last, the significant decline in salaries right now forces professionals, healthcare professionals, to take on multiple jobs, restricting opportunities for deep and long-term engagement.
Thank you, Marina, for your input. Of course, economic crises always pose a very difficult challenge on healthcare, and that has been explored in many sessions and many panels throughout the World Health Summit. So thank you for touching on it. Jagat, would you tell us more about the challenges you face in Sri Lanka?
Yeah, thank you. As we all know, Sri Lanka, though it is a low middle income country, we have free education and free health, and also doing very well in the public health sector, being leading and one of the most appreciated system in the world. So still, but we have challenges as young leaders facing while we are working in the country. The first is the resource constraint, limited to financial, human, and infrastructure resources. So they affect the ability of the healthcare leaders to implement and initiate, expand their services, and maintain the quality standards. So with the current economic and political crisis going on in Sri Lanka, we are facing a shortage of essential medicine supplies and the staff, and also the equipment, as the Marina also stated in her country. The secondly, the lack of the adequate trained healthcare professionals in rural setting as well as in the public, and also engagement of the public health, which is mainly due to the better opportunities in the abroad as well as in the private sector. So they are leaving the government system very rapidly, which is focusing on the professional development of their own. And the other thing is the effective leaders always need to navigate through a complex administrative obstacles, and with the bureaucratic process which is running at the moment, and the delayed decision making, delay in implementation of policies, and that affect severely for us. And this slow down the process of challenges and can affect the delivery of effective healthcare. Thank you.
For the sake of time, Juan, could you please tell us a little bit more about the challenges you say you face in Malaysia and in general in Southeast Asia?
The good thing about being the last speaker that everything have been said. I just want to say a little bit on the multi-regional, multinational leadership. As whatever you guys noted from the previous speaker, I have the chance to lead the Southeast Asia chapter for the World Association Disaster Emergency Medicine. So when we talk about multinational issues, all of these issues that we heard before, it combined with another complex issues. So for example, 11 countries in Southeast Asia, we have different culture, we have different work culture, we have different expectation, different intention. There's a lot of titles given by academic, titles given by the government. So all of this mixed together with all of the issue, with an issue of nationalism, and of course egoism came afterwards. It make the whole things just heighten up. I just want to give you an example. For example, we talk about nationalism. One country might say, my country are doing better in this, therefore why don't you follow me? Another person will say, I'm much more research within this area, why don't you follow that? Just for that notion itself, it can create a lot of friction. So it creates a lot of effect towards that. I mean, you have this, what we call, the progress of projects becomes so slow. There's a lot of what we call this heightened expectation, and there's a lot of very rigid negotiation, and of course, a lot of silent treatment. The blue ticks in the WhatsApp, you can get that quite common. So everyone ultimately, if you don't manage this properly, becomes silos. The thing that we hope to bring people together can actually make people, go quite apart. Yeah.
Thank you, Safwan, on your last point that says when you try as a young leader to bring people together, but so many challenges make us into just separate islands, separate silos that do not really communicate at the end of the day. Okay. It was very interesting across the panel to see so many similarities, how any crisis, economic or political, can affect healthcare, can cause difficulty to access to healthcare, but as well challenges to us trying to navigate a more depleted system, how the public system is gradually driving people out, for people to go more into maybe the private sectors, but maybe just even, abandon completely a system that doesn't resonate with how we as young leaders in healthcare want to practice our medicine. So I would like to, for the second part of this panel, to explore what do you think we can do? What our solutions, what can we present so we can solve or try to navigate towards solving these challenges? What do you think?
Okay, so in China, with regard to the highly competitive circumstance, actually many medical schools and hospitals has already set up some special mechanisms and promotion paths for young people. And the national scientific foundations have also established special paths such as and special programs for youngs, such as young physician or young scientist programs. So these mechanisms helped us a lot. And at the same time, we also need to act in parallel with the competition, such as we have to continuously learning to keep up with the latest medical knowledge and technologies. Yeah, and we have to publish academic papers and participating in the academic exchanges to increase our visibility and influence in the medical field, cultivating our team spirit and our leadership skills. And finally, I think, which is most importantly, we should regularly assess our career progress and adjust our plans according to the medical trends and our personal circumstance. Yeah, I think these efforts will help young physician leaders to better navigate their career paths. Thank you.
Sang, what do you think?
In the problem of South Korea, I think the some people say that AI in medicine can help the problem because in shortage of medical staffs in, for example, internal medicine. I have researched technology that distinguish some true polyps and false polyps while doing endoscopy. And some people say that technology will help the endoscopy doctors to reduce their workload, but it has many things to be happened before its application. So currently, the main option will be the only political thing, the more support from the government to the such department that young doctors are avoiding.
Martin, you're a young leader in Budapest. How do you implement and how do you face these challenges?
I think it's only possible from a bottom-up approach. So I don't necessarily think we can achieve huge changes among current senior staff. To be honest, it's easy to point fingers at them that leadership skills might not be the best quality of them, but we were here at this program only getting to know these skills just now, so they didn't have a chance in their own professional careers. So in that sense, I think we can give them some space, and that's why I believe a bottom-up approach needs to be done, because if we want to change it, first we have to educate ourselves, our own generation, because I think this is a very new field, especially in the Eastern countries, Eastern Europe. And that is not really looked upon, especially in the medical field. And also, I think we also need to engage with our peers, that those who strive to be leaders in their own areas, that they should also build upon these skills and not only their clinical professional skills. Because if we want to change, then we need to first create the need for it, and with that, I think we can expect this to be a relative long change, but I think we need to start it to have a meaningful impact in the upcoming years.
Thank you. Marina, and we're just going to have to be a little bit briefer, so I'm going to ask you to be concise, please. What do you think you can propose as solutions?
Well, in the current context, solutions from my point of view cannot be individual. And to ensure continuity of activities and leadership roles is necessary constant team support and teamwork. And additionally, in Argentina, creating informal networks, which are beyond formal or institution ones, enables resolving supply, management, and healthcare access issues that the system currently cannot address alone. And also, community work with affected communities becomes crucial. And this is Young Physician Leaders is a global network, and sharing our healthcare challenges, of course, is very important. And also, I think caring about other countries' realities and their human rights and standing for every human life. So I think we, as physicians, as young physician leaders, we need to stand for every life and also for every country here. And in Argentina specifically, I think activism for public health and for public education also are essential in this moment where these human rights are being attacked in several ways. So healthcare professionals, especially young leaders, we must commit to public health, to public education, to acquire rights, and particularly in areas like palliative care, medical cannabis, LGBTI health, and in intersex persons' right protection. We must continue demanding improvement and advocating for human rights here in Argentina and also in every country under attack. Thank you.
Thank you.
Yeah.
Jagath?
Yeah, actually, it is similar for any country, which I understand. But focusing on Sri Lanka, there should be a sustainable support and ample opportunities on professional development, research, and while adequate financing ensuring to retain the young leaders in the country is the most important thing. And also, I think it requires strong communication and collaboration between the sectors, and also to develop a mechanism to communicate and collaborate at different levels of the healthcare system and the other sectors, especially the policymakers and healthcare providers and healthcare leaders, for the sustainable development. The third, most importantly, I think as the leaders or the doctors, we have our duty to overcome the resistance to change. So which is very important in implementing new policies, technologies, and also the practices may face resistance from the healthcare workers or other stakeholders who are accustomed to the established system. So which need to change if we are going to go forward. Thank you.
And last but not least, of course, the input of Safwan, please.
I'll make it very brief. As a young leader, you must expect rejection. That is going to be the thing. All right. If you don't get the rejection, you expect you're going to be accepted just because you are there. You're not going to move forward. Expect rejection. I have a lot of things that I want to say, but I just want to tell you a little bit on my secret. If you meet with a lot of difficult people to work with, try to get them into the personal level. And just meet them, talk to them, have a coffee with them, ask about their family, for example. Usually we change from colleagues to friends. It's much more easier. All right. Ultimately, of course, it's about the organization, but it's also about you. You are the long marathon. You have to develop and you have to skill to establish. So I think that is one of the things that I just want to wrap up.
Thank you so much, Safwan. Of course, it's very important to start with communication.
Exactly.
And then go from the bottom up. Try to get your governments, try to get your institutions to, as in they do in China, give promotion passes to young people. But of course, that needs to start with conversation, and of course, with a big focus on all human rights across the board. We're gonna keep the questions for the end of the three panels for the sake of time, and I'm gonna ask my colleagues who will be exploring the gender challenges to take the stage. Thank you.
If we are going to see a real development in the world, then our best investment is in women. Women pay more out-of-pocket expenses in the hospitals than their male counterparts. And then men get paid more than women when they are all in the same level at work. Why is this so? So we are going to look at the gender disparity and promotion of diversity in health leadership. And these are my panel members. You are welcome.
Thank you.
Okay, so I'll start from Zhao. In your experience, gender disparity has an impact on the health outcomes. How do you see this?
Thank you, Esther. So most of you may think, why is she asking a male person to start on this? and it's pretty obvious. I'm privileged, okay? First, I'm a male. Second, I'm white. Third, I'm from Europe. Fourth, I've had an education. Fifth, my parents had an education. Sixth, I'm heterosexual. Seventh, I am not living with a disability. So if you think about all of this, you'll see that I'm privileged. But there's something about us called unconscious bias. And sometimes we cannot see that we are privileged in our positions. And the exercise I want you guys to do right now is to think about the place you work and think about the number of leaders that are females. And next, think about the country you live in. And think about the number of female leaders in your country. And third, think about the continent you live in. And think about the number of female leaders in your continent. And then at last think about the world and think about the number of female leaders in the world. And with this exercise, I invite you all to root for this very important topic that is gender equity. Thank you.
Thank you, Joe. So as Joe is inviting us, Gordana, what impact has the gender disparity has on our health outcome?
Well, data has already shown us that there are more females that work in the healthcare system than men. Yet, the number of women that are on leadership position is far less than men. As a surgeon, my favorite fact is that you have better outcomes of your surgery if your surgery is performed by a female surgeon. So we do our jobs really, really good. And there are better outcomes in terms of innovation and performance. But still, there is disproportion in the number of women and men in leadership positions. For me, as a female surgeon from the Balkans, we face barrier every day in advancing in our careers. That's partially to the expectancy of our societies that we will focus and we will be more responsible for our families and in our homes. So in the long term, that affects our further training and development in leadership position. And when it's a social norm for us to have to be responsible for the bulk of caregiving responsibilities in our home, that usually limits us to take on more demanding roles in the society. And this underrepresentation and gender bias we have in the healthcare organization, usually it limits us to give our perspectives in decision making. And that's why this usually reinforces policies that do not address the specific challenges that women in healthcare have. So do not get me wrong, I know that the number of women in leadership position is rising, but it's not fast enough. And if we know how this can affect the outcomes of having gender diversity in leadership position in healthcare organization, why do not do it like a habit, not just as an exception?
Yeah. So Mimi, looking at all these biases, these challenges that we are facing, and your background coming from Africa, what are the impact of gender diversity on the health outcome?
I think for me, you'll start by defining what health is. And we know that health is just a state of complete physical, mental, and social well-being. So when we look at the outcomes, we're not going to focus on only the disease part, but also the social circumstances and the mental health of our patients. So there's no doubt that gender has an influence on how people experience a crisis or an emergency, or how people actually access health, or how people have access to water, access to education, or even access to employment. So all those barriers that are linked to a certain gender will subsequently have an effect or an impact on the health outcomes. We know how not having access to certain health information or health services, critical health services, not having access to those, even sexual and reproductive health services, not having access to that has an implication. It has an implication on our rates on teenage pregnancy, our rates on unintended pregnancies, on intimate partner violence and harassment, on the maternal and neonatal outcomes, as well as other things like mental health conditions. So there's no doubt that gender has a huge impact on our health outcomes.
Thank you so much. So let's look at equity, diversity, and inclusion. So Yusra, in your field of work, how is this well implemented?
Thank you, Esther, for the question. So my field is public health, and I am in the health policy development processes. While we've seen some progresses in the recent years to promote equity, diversity, and inclusion, but there are still significant gaps. When it comes to leadership representation of women, especially young women, and specifically for women who wear the hijab. Many of these women face barriers advancing into leadership roles due to social and cultural biases. Especially in academia and private sector, biased perceptions and some political views further limit opportunities for these young women, young hijabi women, to rise into leadership roles. Because, inclusion isn't just about diversity quotas, saying, yeah, we have a woman in our cabinet, we have a person from this group in our board. Inclusion is about creating environments where everyone feels valued and empowered to contribute, regardless of their appearance, their background, their religion, their lifestyle, and increasing the representation, as it comes to the answer of the question, increasing the representation of minority groups' leadership in leadership is essential for true equity, inclusion, and diversity.
Sure. That's very great. So Thao, let's do this EDI again. So as a researcher in your field, how is this really implemented?
Yes, I believe that equity, inclusion, and diversity are increasingly well implemented in the field I work in, particularly in research. And as I know, many international organizations around the world and program is support the women in science research, and they promoting their participations and leadership. And for example, one of the biggest that I know is the name is OWSD. This is Organization for Women in Science for developing futures. Under UNESCO, was established one from 1978, and the second one is, as I know, is AWIS. This is the Association for Science in Women, and it also was founded from 1971. And this international forum is actually aimed to promoting the women and unite the women around the world from both developing and developed countries. And they also encourage the women to be the responsibility and ensure some important role in leadership and researchers. And moreover, this group also helped to bring the voice of women scientists and ensuring their contributions and perception to reach the policy, decision and policymaker. And the goal is foster more inclusive and equitable environment, and paving the way for brighter futures for the women in science.
Great. So I'm very glad we have the sciences and then UNESCO supporting women. So Louise, in your field as international crossing borders, how is it gender diversity really well implemented in this area?
Thank you. Well, my background is I'm a gastroenterologist, and I work as a clinician and also as a researcher, mainly in Latin America. And in the first aspect, I think there are several gaps in clinical practice to provide more leadership positions to people with different gender or other characteristics. You can notice when you see which are the current leaders or have the highest positions in medicine. Most of them are men. And I think, at least in Chile, the last 2 decades have been a good time, because we are observing a reduction in those gaps, but we still have a lot of work to reduce completely those gaps. And in the research field, I think there's also a huge problem. it's well demonstrated that any gender have the same capacities to develop good research and obtain high quality research. But unfortunately, if you notice, most of the manuscripts published in my field, the authors are mainly men than women. So that, I think that's still being a huge problem.
Great. This is awesome. So let me come back to you. Want to wrap up? Let me come back to you, Joe. As a clinician, now we want solutions. We don't want to do the talking. We don't want to do the blue ticking. We want to do the action on the ground. All hands on deck. How will you propose to promote gender equity or diversity as a clinician?
Thank you, Esther. So I'm an ophthalmologist. My background is as an ophthalmologist. I work both in clinical surgery and research, and I lead the retinal dystrophies group in my hospital. So we are a small group dedicated to ophthalmic genetics. And again, I'm going to invite you all to do an exercise. If you're in a leadership position and you have to choose someone for your team, the most likely thing you'll do is choose someone that is similar to you, that thinks in the same way that you do, that works in the same way that you do. And this creates some entropia because you are not including diversity in your decision making. So I think the solution here is whenever you're in a position of choosing someone to be working with you, choose the one who thinks differently. Choose the one who looks differently. Choose the one who acts different, because this diversity will make decision-making better. And this has been proven. So diversity in a management decision is better than not having diversity at all. So this is what we have to do to promote equity, not just gender equity, but to include people with disabilities, to include people who have different rationales, who think differently than we do. So this is the way to go.
Sure. So Gordana, we have few women in the surgical space. So as a surgeon, how will you promote gender in the surgery?
Well, I will give and propose a very easy solution that each one of us can do it. Sponsorship and mentorship. If you are on a position that you already know the challenges you face during your journey, help someone else. Sure. Make their path easier. Guide them through it. So that way, if we have like a good and strong foundation, then we can build on it. And if you are a young female aspiring for a job or in a position that a few women or no women before that done it, believe in yourself, try it. Don't give up. I think that is the way that we can start and then continue our path. So that then we can have more women on better positions.
Thank you so much. Mimi, let's come to the hospital, the leadership position, the management position. How will you promote gender diversity in leadership in managing the hospital?
Thanks, Esther. I think for me as a medical manager in a hospital, the most important thing is making it everybody's business. Gender equity, it's not a woman's issue, it's everyone's issue because it's a human right issue. So we cannot deny anyone a human right. So having everyone on board and discussing it, and not just having women sitting on the round table and preaching to the already converted, but having everyone, even men, even people from different diverse backgrounds, talking about the issue. And I've got one of the CEOs in a hospital in Kenya who usually uses an example, and she says, think about it this way. Gender equality is if you give everyone shoes, that's gender equality. But gender equity is ensuring that the shoe that you give to each person actually fits. So it's important that if we give women the roles in leadership, we ensure that we actually empower them. So not just giving you the shoe, but ensuring that that shoe actually fits. So empowering them in different ways, such as what Gorana was saying right now. Ensuring that we give them power, we give them the tools that they need, the skills that they require through mentorship, sponsorship, and coaching, and any other ways that we could use. But the important part is that not give everyone shoes and just go, but give everyone shoes and ensure that the shoe actually fits.
Thank you. That's powerful. I like that phrase, ensuring that the shoes actually fit. Let me come to you, Louise. Once again, we are looking at being at several places at the same time. How do you propose we promote gender diversity?
Thank you. I agree with all the comments raised in the discussion. But from the clinical corner, I think that the equity or inclusion in the early steps of the career of women are extremely important. For example, in my institution, the current number of residents women, it's around 80%. So we are increasing the opportunities of women to access to the specialty. And I think that will be a huge impact in the future decades in the gastroenterology of my country. And in the research field, I think we need to build bridges connecting countries that doesn't have enough opportunities for women to develop a research career and provide resources, funding, and mentoring, as Jordana mentioned. And I believe that that's one of the most important ways to decrease those gaps in gender equity.
Sure. So Tao, let's look at the research. How will you propose that we promote gender diversity in research?
Yes, thank you. Actually, I will totally agree with my colleague because actually I live in Vietnam, and this is a once more Asian countries. And when I live in Vietnam, I think from my opinion, I think promote the gender diversity in science through the target funding is essential because we need to advocate more scholarship, grant, or fellowship for the women in science to have come over the financial barriers. And furthermore, I think the local organizations or private sector should be encouraged to allocate the funding or resources for the women-led projects. And I think this funding force will be very important to bridge the gender gap in science and across not only my country but also in the world.
Great. So lastly, as a health promoter, Yusra, how do we promote gender diversity and take us home?
Okay, thank you so much. I thank all of my colleagues for great, valuable experiences and solution proposals. The topic we discussed is very important. I mean, it's crucial to promote gender diversity in healthcare systems and health leadership. But please allow me to talk from a broader perspective because nowadays all of these feels meaningless when women in Gaza, instead of advancing into leadership, they are dying every single day. And even if they survive, they lose their family members, their friends, their neighbors, their memories, their schools, and their past. So before we can truly promote gender diversity, we must first end the war and genocide and create a safe place, safe environment, safe world for all women. Thank you. Thank you.
Oh, on that note, creating a safe place, a safe environment, and a safe space for women, I want to re-echo two things. That there is diversity in the decision making makes it better. And gender equality is giving everybody the shoes, but gender equity is making sure that the shoes fit. On this note, we want to wrap up our session. Gender equality is not just a woman issue, it's a human issue, and it affects all of us. Thank you so much.
Dear colleagues, ladies and gentlemen, what an honor to moderate the last part of these great discussions. I hope you're having a good time and that we are learning for each other. We are very excited as to be young physician leaders and to have our little moment in front of you here. So let me just invite you to give another round of applause for our new panelists here. So with us, Janet and Carol and Henry and Lucinda and Samagra, so aspiring physicians from all over the world who came here to do some storytelling about their experience, to share their stories. What is this gap we're always talking about? The intersection between research and policy, and how all this evidence that is gathered, all this knowledge, and I would dare to say wisdom, can be translated into actual work. So this is something about me. I'm Aleksandar Stevanovic. I come from the University of Belgrade, medical doctor and a social medicine professional. But I'm stopped there. You are free to scan our QR codes that leads to our LinkedIn profiles if we want to discuss later on. And this last part is all about my colleagues. So we are going to start with Dr. Samagra, who comes from India, my colleague. Please introduce yourself briefly to us and explain how this gap between evidence-based research, for example, in your field as you're a trained gastroenterologist, but you also advocate strongly from primary prevention of alcohol abuse. So how does these two link, and share your experience? Thank you.
Yeah. Hello, everyone. So I'm Samagra Agarwal. I work as a gastroenterologist in All India Institute of Medical Sciences in New Delhi in India. And today I'm here to talk about a little bit about one of the challenges I've realized that is very much evident in the way we do research and its translation into practice. So I work as a gastroenterologist, so I end up seeing a large amount of patients who tend to have complications related to liver disease, which is predominantly alcohol related in our setting. So we see a lot of patients with jaundice, ascites, bleeding esophageal varices, and we tend to manage them, and we believe that we manage them well. But very soon we have them back. In a span of few months or sometimes years, we have them back in the hospital. So over time, I've realized that whatever research we do in this field and whatever work we have tried to do in this field is essentially meaningless because it does not translate to people who actually need it and where it is actually preventable. So if you look at the green part of the slide, this is a part where patients who have started drinking alcohol and they actually do not have a liver disease, which is detectable. And in this stage, a primary care physician or someone who can counsel them regarding their alcohol use can actually benefit them significantly, rather than we who are sitting at the other end of the spectrum and we see them at the end stage of their disease. So over time, I have realized that we as gastroenterologists and people who are sitting in our ivory towers, we should get down and we should actually lead the people who are dealing with patients who are not actually patients, who have come for a regular health checkup and who have come for a routine screening. And they can be counseled better. They can be told about the harms of alcohol, and they can be counseled better to improve their daily habits so as to ensure that they do not land up on the other side of the graph. Thank you.
Thank you, doctors. That was a great point about primary prevention, which we often overlook in our everyday life. And now I just want to go to our colleague Janet, who is also a PhD specialist in public health and biostatistics. So, Janet, we're, from your experience, facing something a little bit different. In alcohol abuse, we have a lot of evidence, abundant research, and so on. But you deal with some kind of diseases that are often overlooked and neglected in terms of research. So what is the situation there, and can you share a little bit about your experience with the neglected tropical disease, as we often call them? Thank you.
Okay, thank you, Alexander, and good morning, ladies and gentlemen. Before moving into the topic that Alexander has mentioned, let me ask a small question, that is, some of you are in the audience are operating the patients, some of you are prescribing, some of you are involved in prevention. What would be your ultimate goal? You may have different goals, of course, but I would say your final goal would be to make a healthy society. So then the real problem comes, what do you mean by a healthy society? A healthy society, of course, it should be physically, mentally, spiritually, psychosocially healthy. And the second thing is, everybody in that particular society must be healthy. And more importantly, people must be healthy in relation to all these diseases. Let's come to our topic. If we really need to make a healthy population in relation to all these diseases, we need to have healthy health policies in relation to all these diseases. In order to make health policies, we need to have an adequate number of researchers in relation to all these diseases. So do we have an adequate number of research in relation to all these diseases? Let me share my own experience. I have been involved in leptospirosis research nearly 10 years now. There are more than 1 million cases per year and more than 60,000 deaths all around the world. So it's obvious that the disease burden is significant. So can somebody tell me what are the preventive methods available for leptospirosis? You might say that doxycycline prophylaxis, of course it's practicing all around the world, but if you look at the Cochrane review, systematic review carefully, it says that doxycycline may not be effective. But if you look at the systematic review very carefully, you will realize that the systematic review even based on only a fewer number of research articles. That clearly indicates that we don't have adequate number of research to make policies related to leptospirosis. It's not only for leptospirosis, but also for many other diseases. So what are the reasons? Of course, the slide says funding. My main aim is not to highlight funding, but there's an imbalance between the research interest and the global burden of diseases. I think it's high time, because future will be our time as young physicians. So young physicians must take lead to make a proper balance between the research interest and, in other hand, the disease burden. That is to make a healthy society. Thank you.
Thank you, Jan. That was great point. That was great point about focusing not only the bridging the gap, but strengthening also the both sides, especially when it comes to research of some overlooked diseases. Now I turn to Dr. Lucinda, who is also assistant professor of medicine and psychiatry at Los Angeles. So we talked a little bit about harmful lifestyles, about communicable diseases, but now we should focus on mental health, which causes a great burden of disease, increasing every day, especially as in developed, but also in countries who are yet developing. So could you tell us a bit more? We have this great gap also between providing health services for mental health and care and well-being. We have some new tools maybe in this area, but are they really bringing us where we should and to assist those who are in need? Or what are your experience and what can you tell us more about this topic? Thank you.
Thank you so much for that question. And I'm an internal medicine physician. I take care of patients, including military veterans at our public hospitals. I'm also a scientist. I conduct health services research to improve population mental well-being. Look around the room. Half of people will at some point in their life experience mental illness. For U.S. veterans, 1 in 5 are currently experiencing depression. They are at 1.5 times the risk of dying by suicide compared to non-veteran adults. We know effective mental health promotion, prevention, treatment approaches are there, but they're not used. Most people who would benefit from evidence-based mental health services do not get them. An implementation gap exists. We know that interventions can work, but we don't know how to get them out there to work in the real world, outside of research settings. Our growing field is called implementation science. That's what you're seeing on the screen right there. It sits on the far right end of the translation research spectrum. We try to understand what, why, and how interventions work or do not work in real-world settings. Implementation science identifies how to overcome barriers to scaling and to achieve public health impact. And we do this using several methods. One, we embed implementation across all phases of research. In the clinical trials that I conduct studying new digital mental health tools, I simultaneously study and measure effectiveness and implementation of routine care. Two, we use non-experimental approaches to establish causality. We look for areas where there is a natural experiment. Not everything can be a randomized controlled trial. For example, the COVID pandemic, different US states decided to enable the practice of telemedicine through different policies and laws, and I study how that affects their state's mental health. Three, we take transdisciplinary approach to generate actionable knowledge. The research teams that I lead include not just clinicians, physicians, scientists, policy experts, statisticians, economists, lawyers. It takes everybody at the table to do this kind of work. So that traditional linear research to implementation paradigm just doesn't work for complex systems where you and I live. There's so many people involved, patients, providers, administrators, technologies, policies, they all interact together. And so implementation science embraces that complexity. It allows for local intervention adaptation, and therefore it can result in successful services delivery at scale.
Thank you, Dr. Lucinda. This is a very great point. Sometimes we think we can do things by intuition and by experience, but actually there's real science behind it, and I thank you that you're going forward with that. And now we turn to Dr. Carol, who is also a science and technology fellow from Philippines. So sometimes I think you want to make a point that there is this research and technology actually in reality there, but it's very hard to ensure the accessibility and to not to make this old mistake that the new technology just kind of potentiates the existing inequalities that are there. So how to ensure this accessibility? What are your experiences in Philippines when implementing some new technologies and wanting to help the healthcare system? Tell us about your experience. Thank you.
Thank you, Alexander. And I will be speaking from a setting of a low to middle income country. So it would be a stark difference from what Dr. Lucinda was sharing. I am currently with the Ministry of Science and Technology of the Philippines, so our mandate is to provide central direction in science, technology, and innovation. So with this, the Philippines is made up of 7,000 islands, more than 7,000 islands. So this is already a logistical nightmare when we're trying to roll out in technologies into those 7,000 islands. So we did this. One example was when we tried to roll out telemedicine in our setting during the COVID pandemic. We already encountered a lot of opportunities as well as challenges. You can imagine that many of these geographically isolated, disadvantaged areas already had problems way prior to just the delivery or the use of the technology. We had power problems, we had infrastructure problems, even on how to bring the technology to the community. So these are the problems we encountered as trying to roll out the research that we have. So it's always nice. It's a nice story to have the technological advancements. It does have the potential to answer these problems in health equity, especially when we deliver services to these areas. Now, we did become proactive after realizing that this was the case. So we worked closely with the local communities, as well as we had to educate them all over again. I know it would be easy for us to use a mobile phone, but in truly rural areas, this is an alien concept even. To just use an application on your phone is difficult to explain in these settings. So with that, we have to work together with these communities in those settings. And as young physician leaders, we have to admit that we cannot do it all. Not one sector can answer our problems with something so complex as health. So with that, we just must lose our ego as well and reach out to the people we need to work with, and as well as we have to give them some of the control. And we have to ask the community what they really need from us and what technological advancements that we need to work for. So as young physician leaders, this is where we sit, and this is where our roles are solidified. And while novel technologies hold great promise in answering these health equities, we must never forget who we're doing this for, the people on the ground. Thank you.
Thank you. Thank you, Dr. Carroll. That was a great point. I agree with the applause. I think we're operating in the real world. Speaking of the shoes that fit, we need to really see what the communities are in need of and not just deliver our technology like that. Well, Dr. Henry, coming from Monash University in Indonesia, you're last but not the least, and I have a very difficult task for you. You have abundant experience of engaging the stakeholders, policymakers, being in the right place in the right time. So can you tell us a little bit more, maybe advise us in this regard, how to engage these policymakers, maybe first to listen and then to actually do something? These are two very different and difficult tasks, so please.
Thank you, Alexander. So how many islands you've got?
More than 7,000.
More than 7,000. So now moving to Indonesia with more than 18,000 islands. So before I start going to my slides, which actually based on my experience working with the policymakers on research during COVID-19 pandemic. So I think first, I would like to talk about the challenge that I observe, especially in my country. I think, in my point of view, many researchers in my country, they didn't engage with the policymakers from the beginning. So they tend to just do their own research, ask research questions that they think important for them, and then they only approach and engage the policymakers after they got the result published. So this often results in misalignment of interest, and it just didn't work that way because we didn't know what they really need on the ground. So what I did during the COVID-19 pandemic is that we got no money. I approached the local Ministry of Health, and then I come to them and said, I could do this and that. Do you mind if I help? And what sort of help that you need? So it turns out that during the COVID-19 pandemic, they have a lot of data, of course, because Jakarta is the epicenter of the pandemics, million of COVID-19 cases. So they work with us. We co-create the research plan. We did the analysis together, interpret the data, and then doing so have been really helpful because then they know the research findings and they can use those information to, directly act on the ground. So, for example, like on the first papers that I published with the local Minister of Health, so they also were part of the co-authors. That ones we were shocked because we found that more than 10% of children under 5 years who got hospitalized by due to COVID-19, so at that time, were dying. So they died. And we didn't know what's going on. So based on that, it triggers more discussion within the clinical community, public health community. And then after that, then they start to think about, maybe it's not only those elder with comorbidities who are more vulnerable. So then they start to, pay attention on improving care for the children. And then it's continue. We continue our collaboration. Then we found out that even in Jakarta, like the capital city, the previous capital city of Indonesia, we still found health inequity. So there are still some hotspot of, geographical hotspot where people are at higher risk of dying due to COVID-19 because they live in poor areas, like highly density areas and with poor healthcare access and those kind of thing. And by doing so, working with them, so they also directly use this data to then, prioritize the public health intervention, for example, like giving the vaccination to that particular population. So I think, the challenge is there, but I think based on my own experience, we really need to engage with the policymakers, starting from planning, implementation, and then dissemination. Thank you.
Thank you, Dr. Henry. I mean, there's so much what we can learn from COVID crisis, and it's still ongoing, and you have brought some very good examples and little tricks of grandmasters, how to get all those evidence and all those policymakers into one team, one functioning team. So these were our panelists with their stories, which are really different, but tell the similar point. And this is how to bridge this gap between research, which is sometimes abundant, sometimes it's not, and to practice and policy. As you can see, we offer no simple solutions, but as young physician leaders, we do offer our enthusiasm and motivation to work on this problem. So I think I'm speaking in the name of all of my colleagues. Feel free to reach out to us, you in the audience, you watching us online, to engage with us, and I hope we will at least our effort, be fruitful to bridge this gap and to make the world, if you want, a little bit better, if not for the generation to come. So I thank you for your patience, and I think it's time for Q&A. But before that, a big round of applause for everybody. And we can go to the Q&A.
If you want to reach out to all the panelists that you just saw, please go ahead and scan this QR code. It would lead you to a page where all of our contacts are listed, and you can contact each of us wherever, whichever specialty or topic interests you.
Okay. So there's a question there.
Thank you for such an engaging session. My name is Alexandra. I'm here. I come from Ukraine, and here I represent International Federation of Medical Students Association. So my question is, in many countries, youth often face barriers where when they are trying to get involved into decision-making process and in influencing process. How can we effectively support young leaders in nations where there is lack of government and social support? So these youth leaders, they will remain motivated and they will be able to stay in their homeland countries rather than seeking opportunities abroad. Thank you.
Thank you so much for your question. We touched a little bit on the geographical and geopolitical realities of each of us in our first session. And coming myself from a country that is currently at war, Lebanon. First of all, and something I really felt when the Secretary General of the WHS said that health is peace. We have to start there and then move to opening a bigger discussion about what our roles are in our specific communities, open a discussion about our healthcare, access to healthcare in the crisis areas. But as Safwan said, try to communicate with the countries around you, with the healthcare providers and the countries around you, and maybe just get out there. And there's a Lebanese proverb that says one hand alone does not clap, so it really needs to be a community effort.
Yes, and also we should have this sense of belonging, as we all come from a country. And I'm glad you are from the International Federation of Medical Students. And when we know that we owe it a duty to our country, we will have that patriotism in us so that we don't go elsewhere. We need to be there to support the country. And we need mentorship. There's somebody in your country that has risen through the ranks up there, making the policy, making the changes. We should look up to that person, reach out to that person, and then those of us also in that high authorities to let's bring the young ones on board. Let's mentor them because they are our next leaders. They are future leaders. Thank you.
I will just say you're doing great work already. So big clap to IFMSA for bringing all those motivated students all across the world together. And we are just there to support you in that cause and to get your voice to be heard louder. So I was a part of IFMSA at my, and I think there are similar stories apart. So already bringing people together, similar interests, similar stories, that's a really amazing job you're doing. And of course, prevention of war, and also where there are conflicts, bringing peace, that for me is number one task of public health. So we should definitely think more about that. Thank you for the question.
Does anybody have another question?
Thank you. I'm Chris Lamar, I'm a physician from Melbourne, Australia. My question is, operations people who run hospitals think very differently from clinicians. What would be your advice to particularly young clinicians who are learning the trade, the craft of medicine, to educate ourselves about leadership and operations so that we can actually learn that language and participate effectively in running health systems, rather than, like myself, learning clinical skills for years and then becoming a young leader at an old age and really finding out this very, very late in life?
Thank you so much for your question. And we, amongst us, there is one of us who is a doctor who is currently in the management of her hospital. So I'd like for Mimi to answer or try to answer your question.
Yeah. Actually, that's a good question, because if you think about it, most of our undergrad as medical doctors, we never get to learn about management or even running operations or running hospitals. It's something that we wing it as we go, most of us. We're thrown into the deep end and we had to swim. But I don't think that's how it's supposed to be. It's supposed to be something that we learn. It's a skill, it's a technical skill. Like there's a say that not all leaders are born leaders. Some leaders were made. So we should be able to say automatically as medical doctors, there's no doubt that our patients see us as leaders and our patients put all their trust and autonomy in us. So we already take up that leadership role from the minute we are doctors and we step into a clinical space. But it's more than just that. It's more than you need the capabilities, you need to be empowered, you need the tools, you need to know how to run an institution and how to know that even the corporate side of the hospital. You know, as a surgeon, you just know that you're operating and you don't know how much is this equipment and the processes of getting this equipment, and you'll just get frustrated and say, but I need this equipment, why is it not getting here? But you don't know the operations behind and how to manage a hospital. So I really think it would be better to implement leadership and operations in healthcare from undergrad level. Yeah. In that way, we'll be able to get all our doctors to have the skill in them. It doesn't mean we're all going to be managers. We all don't want to be managers as much as we all don't want to be surgeons. But it's good to have that skill. We are all in theater, even if we didn't want to be surgeons. So same way, we should be able to get the management skills, even though we don't want to be managers. So yeah, that's my...
I also take it up from here. So there's a need for us to take up the leadership mantle, because in the hospital, if any other person, an administrator, takes the position, they may not listen to you. Maybe you need, as an ophthalmologist, you need a specific machine, but they will go and buy what they want you to use. And at the end of the day, you cannot use that. It becomes a white elephant. So we need to be on the agenda setting table as physicians, as medical doctors, and also we have to run the administration of the hospital. There's a need to also incorporate leadership into our undergraduate study, so that right from the word go, we are teaching them leadership. So in my school, I serve as a part-time lecturer back at home. I teach, and we are trying to modify the curriculum, and I'm proposing that we add leadership to the curriculum. And then we also have to build ourselves. It's not too late. And I'm glad you said you are now a young physician leader. Yes, it's not too late. Why don't we pay and go and have the capacity building? Why don't we pay and get the knowledge ourselves? Why don't we pay after getting the knowledge? We should push ourselves to that level. If it comes, when the application opportunity comes, apply and be there so that nobody tells your story. You are there to make the decision on behalf for doctors and physicians all over. Thank you.
Thank you, Esther. I will just continue on your question. What is the advice for young people, for medical students? All of this is true, but my advice for them is just have fun and don't burn out. We need you in clinical medicine, and all these excellent suggestions that we have are for the deans and for the leadership of the faculties. We need them to change the curricula. So we need this extra pressure that might also come from students, but even more it should come from international community to change the curricula in order to have tomorrow the medical experts that can answer to all of these issues. Because right now, I mean, we are having AI involved, and of course, we're dealing with some kind of dilemmas there. Like, should we actually force our students to know diagnostic criteria by heart and so on, or should we develop their communication skills, their leadership skills, something that AI cannot do yet? So my bet is on that, and I fully agree that we should change the curricula and build more leadership in medical schools and other healthcare professions.
Thank you, Alexander. Anybody has another question? Yes, please.
Hello, my name.
Yeah.
Hello, my name is Liliana, and I'm here from the Youth Side program of the German Medical Students Association. Thank you very much for all the talks, very inspiring. I would like to, a very general question maybe. I am a medical student here in Berlin, and I have already made some experience in the clinic and have been, for example, in the operation room. It is hard for me to imagine myself as a leader when I assume this position, when I come into the clinic, when I finally start having my internship, or I start assuming responsibilities, especially sometimes in some fields, like, for example, here in my experience, the surgical, the visceral surgery, which is composed by men mostly. How can we view, I believe that leaders can be also made. They're not necessarily born. How can we assume a leadership position in such a young or early stage in our careers? Thank you very much.
Thank you for your question. I'm going to ask my colleague, Dr. Gordana, to chime in on how to bridge this phase between being a young physician, just entering the medical world, and then going all the way up into surgical leadership.
Yeah, so I had that path, and actually I'm still walking it, because even though I'm a surgeon for a couple of years, I always get the question like, well, you're too young for this. I still get my voice not heard often enough. But you have to be persistent, not to give up on your dream. So you have to leave your passion to be very expressed in what you do. You just try to be your best. Try to find people in your surroundings that can support you. And if you ask for help, I don't think that if you have an inspiring person around you that will not take the challenge to lead you through it. But the first one is believe in yourself and don't give up. You'll always have the chance to speak up. Maybe not always, maybe sometimes it's still smart to choose your battles, but you will get there if you want to.
Thank you, Gordana. I like that you touched down on the very important issue of mentorship. Ask and find mentors around you. There are many people around you, and I'm the first one when I was a younger med student not to ask around me what people would think, because, well, we have that I know best, or the other side, I'm too ashamed of what they're going to think of me. But find a mentor around you and have this discussion, not specifically about one career path, maybe you want a diverse path, but building strong mentorship relations and sponsorship is very important.
Not just that, you know the song. It's a man's world, but it's nothing without a girl.
Any other questions? Let me then wrap up our session by going back to a little bit of the challenges we described this morning, whether from economic crisis around the world affecting healthcare delivery, whether from rigid systems and rigid hierarchical systems like Martin touched upon, rigid systems also that allow for one way of progress, one way of doing things, and how could we address all of this? Maybe start by questioning our privileges, as Joao went ahead and said, have a discussion, as Safwan said, across countries, but also across different actors, because oftentimes you have very various people around the field that are trying to implement healthcare policies, or just even in clinical practice, have a discussion going around everyone. And as you said, make it everyone's business, because it is everyone's business. And maybe along the path, you will always reassess your careers. Do not think that it's one linear path. Tiange said that reassess your career path. You will think where you are at some point and go back, and if you need to change, if you need, maybe you'll have a discussion with your mentor and take another path. And very often think about how you're going to propose the changes that you are going to bring forward. Do you want to go from the bottom up? Do you want to make sure that everybody has the shoes that fit? Mm-hmm. Do you want to be more of a vocal discussion person? I think all of these are solutions that we will try to implement during our future years.
Maybe, sorry, Esther, do you want to? Maybe we can benefit from Peter once again speaking, wrapping up. Next year, there will going to be a new generation of young physician leaders. So should we just tell them how they are able to benefit from these opportunities, how the process goes, and how they can reach out to you if they're interested in this program and so on? Where is the call going? Thank you.
Alexander.
This invitation to try and close out the session. So I mentioned at the opening, this is an annual call for young physicians nominated through either your national academy, the member academies of our organization, the Inter-Academy Partnership, IAP, or through one of the World Health Summit Academic Alliance members, so either route. Again, there it's essentially finding the person, the sponsor that will put your nomination forward. I think that's important. Then there is a selection. The call usually goes out around May, and then there's a selection around June, July, so that we have time for the visas and everything. And I think it's a great opportunity to do exactly what has been discussed here, to fill the gap in the undergraduate medical training. And this was the real incentive why we created this program 11 or 12 years ago, and to be part of that sort of peer support network that now has 280. Some are younger than others, because some have aged 10 years or more in the process. But that's also valuable for those coming in as fresh alumni to the program. So maybe I can just take this opportunity to thank all our presenters. You all did a wonderful job. The time pressure for the preparation was against you. And maybe we can all give them all a round of applause for what